I think people, when they hear that I do palliative care, they're like, oh my God, that must be depressing all the time.
Super sad.
Must be miserable. Sometimes people think that I'm there to talk about death and end of life, things like that. When you talk to patients about those types of things, though, what you end up talking about is really their lives, where they're at in their life right now and where they want to be.
Right. Welcome back to the Move Room. My name is Catherine Reber, and I'm a doctor of physical therapy working for Kinetic in Westchester, Pennsylvania. And today I'm joined by Dr. Brian Sprandio, who is a community-based palliative and supportive care specialist, and he works for Consultants in Medical Oncology and Hematology, located in Broomall, Glen Mills, and Newtown Square.
Yes.
Well, thank you so much for joining us today.
Thank you for having me. This is really nice. I was just saying, this is a beautiful studio.
Yes, exactly. Welcome to the Joe Rogan podcast of healthcare.
I'm trying to appear as comfortable as possible right now, but this is making me no, I'm kidding.
No, it's going to be totally good.
Okay,
We're going to have a great time.
This sounds great.
So take me back to pre-med school, pre-medical journey.
Yeah.
What were you like as a kid in high school and everything?
Yeah, so my dad was a doctor, is a doctor.
Okay.
My mom was a nurse. So I always was interested in, medicine to a degree, just, being around it.
Yeah.
So much as I went through high school, college, realized that was probably the path that I was going to be taking. Mm-hmm. Took a bit longer for me to get there, but I did get there. I went to medical school at Temple, which is called the Lewis Katz School of Medicine now. I graduated medical school in 2015. Went into residency at a family practice program at Bryn Mawr Family Practice. And after that, I did a fellowship in palliative care. So while I was in residency, I met a lot of patients, both on the outpatient side of things and the inpatient side of things, that had a lot of things going on in terms of their medical conditions that were challenging to treat, and even more so, challenging to, navigate every day with a lot of symptoms. And I realized that, patients who have a lot of different things going on need a lot of support. So to me, palliative care became a way to meet that patient need as much as possible. And also, build relationships with patients that probably need good medical care more than anybody.
Sure.
Yeah.
And is it one of those things that you feel like you can spend more time with clients and I'm sure, other just normal medical systems where it's kind of fast paced and stuff like that?
Yeah. So one of the things that drew me to outpatient palliative care, I was an inpatient palliative care doctor for a couple of years, right out of fellowship. And inpatient palliative care teams do excellent work in the hospital. They help a lot of people. I always felt like it was hard for me personally, because what I was finding was I was meeting people for the first time, patients, in these really acute settings where they're feeling really sick, and they are really sick, and they have a lot going on. And I'm meeting them and their families that hospitalization. And a lot of time, it's really hard to, accomplish a lot when you're meeting someone for the first time, when they're not, doing their best.
Totally.
Or feeling their best.
Totally.
When someone's in the hospital, first of all, the patient's main goal is to get out of the hospital. The family's goal is for that person to get out of the hospital. And even the people that work in the hospital, their goal is to get that person out of the hospital doing better too. So, it was a lot of, for me, it was hard to navigate that type of setting, and then also help patients and build longitudinal relationships with people on the inpatient side of things. So I was drawn to doing more outpatient palliative care. My dad and my brother are both oncologists at Consultants in Medical Oncology and Hematology.
Gosh, amazing.
And
family business.
Yes.
That's so
cool. We talked about things and talked about how great it would be to have embedded palliative care in the outpatient setting within a patient-centered medical home practice.
Okay.
So I've been there now for a little bit over 4 years. And just like I thought, for me, it's better to practice palliative care in the outpatient setting because I can get to know people.
Right.
I can bring them back when I want to bring them back. and we can work together, not just as patient and medical provider, but also with the oncologists in the group,
right,
who are different than a lot of other specialists with regard to the fact that they're really into the idea of palliative care and understand the benefit for patients and their families.
Okay. And is the outpatient palliative care business, is that a newer thing that has developed over the years? Like, has it always been an inpatient type of service?
I would say so. Yes, that outpatient palliative care is a newer thing within the last few years.
Okay.
Most people who encounter someone from palliative care, and this is still the case, their first encounter with them is probably in the hospital. And in the hospital, the way that it works is, a hospitalist and other specialists will say, this patient's really sick. I'm not sure how much these treatments are going to help. I'm not sure how much I have to offer them. I want them to see a palliative care person. Or this patient has horribly controlled symptoms that may be beyond, their scope of, being able to treat. This person needs to see palliative care.
Okay.
Or they'll say, this patient's been in the hospital a few times within the last couple of months. They're not doing well. They need to have what's called a goals of care discussion or do some advanced care planning in the hospital.
Okay.
All of those things were kind of on the table in the hospital. And you can imagine it's hard to accomplish those things in the hospital. Again, inpatient palliative care teams do it really well. But I always felt like I wanted to make the jump to outpatient to really tackle those things in the outpatient setting.
Sure.
So I was drawn to that while I was doing inpatient palliative care. And everybody that I work with is great at identifying the patients that need to see me.
Sure, absolutely. Can you talk about the difference for somebody who may not know? What's the difference between palliative care and like hospice care? And like kind of when does that transition occur, whether you go to one versus the other?
Yeah. So I would say, the difference, if we're talking about like the main differences between the two, and I'm glad you asked that question because I get that question so often.
Yeah, I think it can get confusing. Like even if you look up on Google, it's not always super clear.
And the reason it's confusing is because people that work in medicine are confused too. So they don't explain it really well to a lot of patients. They don't talk about it the right way amongst each other.
Sure.
So I think when people hear palliative care, they automatically think, oh, this is end of life care. I'm out of options. I don't have a chance. What I have is not manageable. And that's not always the case. I would say palliative care is available to anybody that has any type of illness that's creating a really complicated symptom burden or creating a lot of distress for them. And people can experience distress in so many ways.
Sure.
It's physical, spiritual, emotional, mental. And that's why I'm there. Now, hospice is a Medicare benefit that's available to patients who have decided that they're at a point where their main priority is focusing 100% on their comfort and managing their symptoms. And so a hospice patient is someone who makes the decision that, I don't want to have to go back to the hospital when I have an acute medical issue. I want my symptoms managed at home. I want to maximize time with my family with good symptom management. And hospice is meant to occur really at home.
Okay.
Surrounded by, a home hospice team.
Okay.
And family members that are also assisting with care.
They will actually come to the home to help manage them. It's not like they're coming to an outpatient practice per se.
Right.
Okay, got it.
Now, those are patients that have really decided that that's the goal. They don't want to have to go to all these different specialists anymore. And people make the decision on hospice for a variety of reasons. It might be because, really aggressive treatments for their disease left them feeling more sick. It might be because they're having a really escalating severity of their symptom burden. Their symptoms have just gotten too severe. Or it might be that they're thinking about the end of their life and what they want that to look like, not just for themselves but also their families.
Okay.
Yeah.
Do you guys do any sort of that, or do you end up sending, talking to a different hospice care team?
Yeah. I have, multiple agencies that I refer patients to.
Mm-hmm.
And we make sure that the transition is smooth, whatever decision the patient makes. We have, agencies in the area. We base it mostly on location.
Okay.
So whatever agency is closer, all the agencies are great.
Mm-hmm.
Home hospice teams do phenomenal work, and they probably do some of the hardest work that you could, imagine in medicine. So yeah, we work very closely with them. A lot of times when a patient transitions to hospice, they'll make sure that I'm like the primary attending physician for them, because I've gotten to know them, and they want the hospice team communicating with me directly about any changes in symptoms or any changes in medical management.
Okay. So at CMOH, how many people are you working with there? I mean, are there multiple different physicians and support care, and kind of like, where does everybody's job fall in place? Like, do you guys work together as a team?
Yeah.
Does everybody have a certain, diagnosis that they see? Talk to me about that.
Yeah. So at Consultants in Medical Oncology and Hematology, it's hard to say, CMOH, there's multiple oncologists there, all who work really well together. Every new case is reviewed among all of the oncologists. Okay. There's me, who does palliative care there. There's a dedicated team of nurses that work in the infusion area, and MAs who help get labs on the patients. We all work together. There's a spiritual care counselor that works with us, who does a lot of great work seeing patients while they're getting infusions a lot of the time. I think the thing that's unique about us is we're all in the same building together. Yeah. We're all sharing space together. We're all curbsiding each other all the time about what the best approach to managing a patient's, illness and also their distress. How can we work together to make sure this patient has what they need? We are unique in that sense that we all work directly with each other.
Absolutely. And I'm sure the patients and even their families appreciate that you guys are able to communicate so easily. Yeah. Especially when they're dealing with probably a very stressful situation. Yes. It's something that I know that people definitely would struggle with if they had to kind of go through hoops and ladders to find different people to take care of their symptoms in different ways.
Yeah. And I would say, like, when I started, when people would hear palliative care, they would get anxious and nervous and be worried about meeting me. But we work in such a close-knit community and area, kind of like in the heart of Delco, where the oncologists do a good job at explaining what I do, but patients also explain what I do to other patients. Yeah. So if another patient is anxious, patients become friends when they're on the same chemo schedule. Yeah, that's and they all cool. Talk to each other, and so we like to think that we're making sure that we're always, giving patients the right information about, what they need, but also, they're doing a lot of that work for us too. Totally. So, if a patient has some apprehension about meeting with me, I can usually diffuse that pretty quickly by just telling them I'm here to do whatever they, need help with. Yeah. But also, there's oncologists that back me up, who, really kind of ease that transition. Yeah. And, the patients do it as well. They're like, he's great. You're going to be just fine. I don't know about that. No. I don't think anybody's ever said that. But yeah. That's something I love about my job too, because obviously in the physical therapy clinic, there's multiple patients at a time, whether it's with your coworkers. Yeah. And, especially when you are going through, different case but injuries that, really put your life to a halt, right? But talking to other people that are, maybe going through something similar does create a nice community and bond and get them to a place where they actually enjoy coming and working on themselves. It really, that mindset really switches things in terms of their recovery process. Yeah. And to your point, when, oncologists have different training than, palliative care people. Yeah. But we work really well together if we work closely together. Yeah. When we're all kind of, under the same roof working together, it makes things a little bit more streamlined. Totally. And, achievable.
Yeah.
Yeah.
Tell me about your day to day. Like when you walk into the office, what does your typical day go like?
Yeah. So when I get into the office, I'm usually making a priority list in my head about who's, a main priority to follow up with today.
Sure.
So I meet new patients all the time. I do follow-up visits all the time. And what we do that's unique is we'll do coordinated visits, which means when a patient sees their oncologist, they oftentimes will also see me on the same day.
Awesome.
So you can imagine, somebody who has, dedicated oncology training is really there a lot of the times to focus on the cancer, what this cancer is doing, how it's behaving, and giving updates about, what the next options are. They do a great job of, identifying symptoms and managing symptoms, but then I can spend a little bit more time focused on that.
Sure.
And I can give the patient an opportunity to take a little bit of a breather in terms of just, medical information that is coming at them.
Absolutely.
And you can imagine, how complicated things can get, not just for patients, but for the oncologists. And if it's complicated for the oncologist, you can imagine how complicated it is for the patient.
Right.
So I hope that I give them an opportunity to say, okay, here's what I just talked about with the oncologist to kind of understand these things now. And I'm wrapping my head around some things. And then I can come in and say, well, tell me more about how you're feeling.
Right.
And maybe they heard a lot of new information that day. They might just be wanting to talk to me about what they're thinking about everything.
Totally.
And I kind of relish the opportunity to see people in a room if they have a family member there with them too, because I want them to know that, for me, my goal is always, how can I help you right now? Now, for some people that's, get this symptom under control and that symptom under control. And, I haven't slept in 3 weeks, what can I take that's safe for sleep right now? Or I had a change in the status of my cancer, and I need to do more thinking about what the next best step is.
Right.
Maybe they're saying, look, I've done some advanced care planning, but I want to update my, medical living will.
Right.
I'm going to help them with that.
This is making me just feel calmer just hearing you talk about it. Seriously, but I'm just imagining somebody who's hearing some pretty heavy news that otherwise may just be getting in their car with a family member and breaking down, crying, what are my next steps? What am I to do with this information?
Yeah.
That's so nice that they're able to kind of go right into your office and just kind of talk it out. Like you said, what can we do right now to help, better this situation a little bit, or just know that you have a little bit of control?
Yes.
Like, how can we put some control to this? Because there's a lot of things, especially with that type of serious illness, that I'm sure is out of their control to a degree.
This is probably the most important word. I'm glad you brought it up, but control. I think, patients are always worried about dying. They're worried about getting sicker. But the main thing that they're worried about a lot of the time, I think, is losing control.
Sure.
And if we can give them a better opportunity to gain control of some things, maybe it's, their symptoms, or maybe it's their communication with their family on what exactly is going on.
Right.
We can help them with that.
Right. So we talked a little bit, or you were kind of mentioned it, but some of the things that you're talking to the patients about in terms of, all the different things that you could see. Talk to me about the most common types of symptoms or discussions that you may be having with them post, a big appointment like this.
So the most common symptoms that I treat, and there's a lot, basically it's any symptom, but the most common ones and some of the most difficult to treat are things like cancer-related pain, because there's a lot of different ways that a cancer can cause pain in the body. Sure. So, my job a lot of the time is to make sure that that is not as severe, hopefully, and less frequent, and better controlled. Then there's other symptoms that can be related to cancer, or they can be related to treatments from cancer, like nausea, vomiting, constipation, diarrhea. These are all symptoms that I'm treating every day. Insomnia is a big one. I try to make sure that I'm doing a thorough symptom assessment with everybody that I see, because, like I just mentioned before, my goal is always, what can I do to help now?
Sure.
And, sometimes symptom management can be easy. And if their sleep has been horrible for 4 weeks, I can get them sleeping better within a couple nights.
Right.
And then sometimes it's really hard. And it's a little bit more trial and error.
Sure. And are you doing this medicinally, or is it more conservative treatments, or a little bit of both?
So I use medications. A lot of the time, if a patient's really struggling from certain symptoms, we can give them certain things in the infusion area, whether it's, fluids, steroids, anti-nausea meds, things like that.
Okay.
I certify people for medicinal marijuana, which is something that people are, really
Huge
interested in. So, a lot of things. And a lot of people I meet, they have really complex symptom burdens, and there's a little bit of trial and error component sometimes.
Sure.
Where I have to say, look, based on your constellation of symptoms, this is the thing that you should be on. These are the meds we should change. And if it's not working in the next couple of days, you're going to call me and we're going to do something else.
Okay.
Because a lot of the times, with complex symptoms that I encounter for patients, the question is always, what's the right medication for me? And if we're having trouble finding something, I always say the right medication for you is going to be the one that works.
Sure.
And we just haven't found it yet. And we usually do find, something that works for the really more complicated situations.
Sure.
But, it can run full spectrum from things that are relatively easy and straightforward to treat to things that are really more complicated.
Sure. Are you primarily treating people with cancer, or are there other chronic illnesses that you see quite frequently?
Yeah. So I don't see only cancer patients. So we meet a lot of patients that maybe are, yearly hematology patients to get their iron levels checked, but they also have, a lot of comorbid conditions.
Sure.
Like COPD or congestive heart failure. And, for patients that have, maybe they don't have a terminal diagnosis or an advanced cancer diagnosis, but they have multiple really complicated things going on that can create a lot of symptoms. They're sent to me. I get patients from outside the practice too. So neurologists will sometimes send me people with, advancing dementia.
Sure.
I'll get patients that are being seen by nephrologists who have, stage 4 kidney disease and might be headed towards dialysis at some point. And maybe that's not something that is, something they want to do.
Sure.
I have patients that have, severe COPD, like I mentioned, a lot of like lung diseases like pulmonary fibrosis, COPD. These are illnesses that can definitely limit your functionality and, cause really hard to manage symptoms.
Sure.
So a specialist in the area might say, look, this patient has stage 4 COPD or really bad pulmonary fibrosis, and their oxygen requirement is constant and it's increasing. I need you to see them, and I need you to talk to them about symptom management, and I need you to talk to them about, getting readmitted to the hospital, and if they want that, and where they are in terms of, how they're feeling about everything.
Sure.
So it's kind of like a loaded thing sometimes where it's like, okay, where do I start?
Right.
But my goal is always to like keep it really open-ended with people.
Sure.
And, start off by saying, so-and-so sent you here. It's nice to meet you. Tell me how you're doing.
Right.
And, sometimes it's a completely different visit than I thought it was going to be.
Right.
And, other times it's really symptom focused. I like to keep things pretty open-ended for people.
Sure. Are there times that you yourself are referring these patients to like rehab programs or something like that? Or is that not necessarily the most important at that stage in their illness?
Yeah. So, I send patients all the time for physical therapy, pulmonary rehab, cardiac rehab. These things are things that help. It doesn't matter how advanced an illness is. I have patients that get physical therapy, occupational therapy at home. I have them, getting it outpatient. If I see a benefit for that,
right,
I'm going to send them.
Right.
If it's a patient that's had a lot of different things going on that, really is, limiting their ability to live the way that they want to live.
Sure.
And they're a type of patient that can, rehab.
Right.
I'm going to send them.
Right.
Yeah.
And what are the, like, when you're communicating with PTs, with the OTs, what are the goals that you're expecting out of it? Like, you know, I'm sure it's not something that you're expecting to see major progress every couple of weeks, right? It's probably slower, if anything, more maintenance, right? Or what do you typically talk about?
I would say, you know, it really depends. You know, it depends on, you know, the severity of, you know, what they're going through. And like you said, maybe functionality is so limited that they're not going to gain a lot, but, you know, maybe they will. And if a person is really kind of focused on rehabbing, you know, I talk to people a lot about their goals, and a lot of times people will tell me, you know, I want to get stronger, you know, and, you know, maybe I'm starting them on, you know, an appetite stimulant, and, you know, trying to see if they can, you know, kind of turn things around a little bit for themselves.
Sure.
And then they'll go to, you know, physical therapy.
Sure.
So, you know, but if they're really, really advanced, unfortunately, there's a subset of patients where they're not going to be able to do, you know, the physical therapies and things like that.
Sure. I'm sure we'll have some PTs or even OTs that listen in on this, or even honestly like personal trainers. Is there any advice that you would give to them just in terms of like listening to the patient, or like, you know, certain vitals that they should be watching for, things like that when they're treating somebody, you know, of any of, you know, whether they're a cancer patient or whether they're COPD, CHF?
I would say, you know, the main thing, I think, like, the way that we do things as, you know, health providers, like all of us, the mindset is always push people as far as they can go, right?
Sure.
And, you know, for some people that's doable, but for a lot of people it's not. And, you know, depending on what they have going on, if a patient, you know, is being seen in a physical therapy practice who has a lot of limitations, and you're worried about them, not just, you know, about their safety, but about, you know, what's going to happen to them. What is the next thing that's going to be a major, you know, barrier for them?
Sure.
Yes, the vitals, the changes, all those things matter. But I think always seeing if you can take a step back, and, you know, you have patients that you're rehabbing from an injury that you want to see, you know, advancing all the time and you're gaining functionality. It's okay to see somebody and maybe have a little bit more of an open discussion about you know, what's doable. I think the best thing in all of this, it doesn't matter if you're, you know, a doctor, a nurse, a physical therapist, is, you know, taking a step back and really understanding, you know, what's going on in a patient's life.
Yeah.
I think that's really important. Just like understanding their life, their day-to-day life. And that's hard to get sometimes in just a quick visit.
Totally.
But when you see someone repeatedly, you start to pick up on things.
And I think a big thing too is just open communication. And that's, you know, from a physical therapist perspective, that's on us too, to be communicating with the physician that sent the patient, right? And just making sure that we're all on the same page. Like, these are the goals. These are the things that we want to either work on maintenance or just get a little muscle activation, or is the goal to kind of push into that next step, right? Because I'm sure, you know, there's probably some patients that, you know, maybe get in denial. Like, this is not actually happening to me. I want to be pushed. And that might not be the best case for their health and for their safety. You know? And it's like patient education is probably huge. Patient education is huge.
And that, I think, you know, I see that a lot because I think in medicine specifically, like I was saying, you know, the goal is to push someone and, you know, as far as you can.
Right.
And really, we all need to be aware of what's going on with the person, and have a willingness to really talk about where they're at and what's important to them. That's hard for people to do because, you know, if you're a specialist and you're trained in, you know, cardiology or oncology or neurology, you're really focused on, you know, that specific area, and that's fine and that's important. But where I come in is, okay, tell me about all these appointments you've been to. Tell me where you are. Tell me what your understanding is of everything. And tell me what you want your life to be. You know, sometimes people think that I'm there to talk about death and you know, dying and end of life, things like that. when you talk to patients about, those types of things, though, what you end up talking about is really their lives, where they're at in their life right now,
Right.
and where they want to be.
Right.
And I think people, when they hear that I do palliative care, they're like, oh my God, that must be depressing all the time.
Super sad.
It must be miserable. That must be horrible. And there are some things that are so sad, like, as you can imagine, and as probably you've seen by some patients that you've met. But there's also, I think people, the old mindset is like, palliative care is for when everything else is failing, but there's a lot of success in palliative care.
Absolutely.
Too. There's success stories, and a success story to me is meeting a patient that has a lot going on, and making sure that the things that were making them feel like they lost control completely are restored in their life.
Totally.
And sometimes we can do that, like I said, by getting them to just feel better day to day, so that they can focus on what's important. And what's important really for everybody is, their lives and the people close to them.
Yeah. And that's where I feel like we have similar concepts of our job, us too, because that's another thing from PT. Like, they could be going through so much. And when I was a new PT, it definitely was scared when I would see somebody that had all these comorbidities or they had a chronic illness. And it was kind of one of those things of, oh gosh, how do I treat this? How do I go about this? And I remember some of my mentors at the time were like, don't overcomplicate it, and just help that patient get through that day. Or like, this is something that we do have control over, is being able to flex your quad today. And that's huge. You know what I mean? Just being able to like pump some blood to your body, just the little things, just phrase it in a way that's what we're trying to work towards, is just give you that little bit of control as you're going through this, process.
When I was a family medicine resident, I would meet a lot of patients, outpatient, and some people would come to me with a lot going on, who are really sick. By and large, in a family medicine residency, you're meeting people who are very ambulatory, that walk into the office and you're focused on one thing. But then you would meet people that were dealing with so much. And I remember having those visits and just being completely like overwhelmed and wondering, like, where do I even start? And getting training in palliative care, I can meet a person, talk to them for a little while, and I can know where to start with them, and how often I need to see them.
Right.
And I know that, if I can help them with one thing that day, we can build on that a little bit.
That's a win. It's a rewarding job, it seems like. And again, having that access to everybody in where you work and being able to talk through with that, and just making sure everyone is on the same page is amazing.
Yeah.
I want to ask you, do you feel like, because I think there's been so much, change in the cancer world in general, do you feel like there's certain types of cancers that you guys see pretty frequently, or is it kind of everything? We see everything.
Okay. And all of our oncologists see everything. And if there's ever a situation where our oncologists feel like if they need to be seen at a bigger center or, somewhere downtown, they'll send them right away. But we see every type of cancer.
Okay, gotcha. I wanted to ask too, like, when somebody receives, like, if it's their first day, they've just found out they have cancer. Briefly, like, what does that process look like going forward? One of the hardest things is meeting someone new who's still learning new things every day and getting tons of new information week by week about what's going on inside their bodies. And finding out more about why they're feeling so sick. That's really hard. It's hard for the patient, and it's hard to direct a patient in those situations. What I mean by that is, like, if a patient has a new finding on a scan that their primary care doctor ordered, and then they're sent to us, we need to find out what it is. There's blood tests, there's biopsies, there's all different things that, a patient needs to go through. We do that quicker than most. There can be days that go by, weeks sometimes, where somebody who's sick and knows they're sick and knows that it's cancer is waiting for, information and a treatment plan. So that's really, really hard. And it's almost impossible to talk to somebody about how to handle that. I think that, people find the best ways to handle it, based on what works for them usually. But, even patients like that,
I can meet them before they have, their established diagnosis, and I can say, here's the symptoms I'm going to work with you on right now. When we see you back next week and your treatment's planned, we're going to talk again. We're going to see if you're feeling better. And if you're not, we're going to keep working.
Sure.
Yeah.
Do you have like a clinical pearl, like piece of advice for somebody who may be watching this who was just diagnosed with cancer, or somebody who's watching this whose family member was diagnosed with cancer, or a doctor that's watching this, or a PT, OT, whoever, who has a patient that has cancer? Like, what is one thing that you would say to like help ease the situation slightly?
Yeah. So,
or something that you talk to your patients about?
Yeah. So it's hard to give good advice that doesn't sound like a cliche at such a bad time for people. What I tell people to do is the things that they've always done throughout their lives, whenever they've encountered something difficult. And that can be previous health conditions. Mm-hmm. It can be something that somebody in their immediate circle or family went through. It can be emotional challenges that they've dealt with. It can be mental health challenges that they've dealt with. Mm-hmm. Whatever they do to kind of like recenter themselves, do that and lean on it. In the meantime, I want to find out how I can help. So how can I protect your sleep right now? Mm-hmm. How can I help with your stress and your anxiety? Mm-hmm. Sometimes, people feel like, okay, I just talked for, an hour with this person and they leave a little bit more, I don't want to say reassured, because it's hard to give reassurance in a situation like that, but comforted maybe. If a patient feels like they're being heard and listened to, which is more unique than you would think.
I know. You're stealing the words right out of my mouth.
That can make a big difference.
Sure.
So, is that going to fix all their problems in that interim of, when they're getting their diagnosis and starting treatment? No, of course not.
Right.
But it might help a little bit.
Yeah.
And if I can bring them back the next week, I can keep a close eye on them.
Right.
And kind of build off of that initial visit.
Sure.
When we start people on treatment, we can always tell them things to expect because we know what drugs cause certain symptoms.
Right.
We know if a person has a specific type of cancer, what symptoms they might be experiencing on the horizon, if they haven't experienced them yet. Mm-hmm. So we can prepare people that way.
Sure.
And I can't think of any other practice other than ours that does that better for people. Mm-hmm. There's tons of education for people when they walk in the door, especially on their, initial treatment days. That can be overwhelming, but, to in terms of just like expectations and telling them, what to expect or anticipate, we can tell them certain things. We can't tell them everything though. Yeah. And that's why I tell them, if you're feeling like something's changing, it doesn't, if it's a symptom that's getting worse, if it's a new symptom, if it's a changing symptom, if it's something that you think is small, you have to call us right away. Right. And the reason I always tell people that is because, one, like I have said a few times, I want to help people now. Mm-hmm. And then two, the person is maybe coming back for treatment next week. I want them to have that symptom under control so that they can get the treatment that they want to get next week. Right. If they're too sick, we have to have a discussion about, okay, we have to delay this right now. Right. Having palliative care involved, the patients get the attention that they deserve. Right. And they get the management that they need. Really. Right.
And like you were saying earlier, just being able to be heard goes such a long way. Like I even hear it from my own clients of, whether it's a negative experience they've had in any medical professional setting where they couldn't even spend 5 minutes with the person, right? Because it was just rushed and, they just couldn't get out what they needed to say. But even, whether it's a small issue or whether you're dealing with cancer or a serious medical issue, I think that probably matters more than any of us think, of just being able to like sit down with somebody, be heard, someone to take the time to address your symptoms right now. I mean, even just you sitting here on this podcast, you can tell how much you care about all these patients. And I think that's all they want, is somebody who actually like cares about them, sees them, and hears everything that they're saying.
Yeah. And I think
it's awesome.
I think one thing that's uniform across all patient populations is a patient can tell when you're listening to them.
Totally.
And they can tell when you're thinking about what's important to them.
Totally.
Yeah.
I've even noticed that in my setting, if I'm kind of on the computer and I'm not really making eye contact, I'll notice that they say things doubled over, or they'll say it again because I think they think I'm not listening, but I'm like, all right, body language really matters when you're a healthcare professional.
And I'm not saying I do any of this perfectly, but yes,
Me too.
How many times when you're doing these things are you like
multitasking?
I was multitasking.
Yep.
I sounded short.
Yep.
It happens all the time.
Yeah.
And I think those things really matter to patients.
Totally.
And they should.
Absolutely. Yeah. Do you guys do any like prevention type work, for somebody who, let's say, has like a family history of some of these different illnesses? Is that something that you guys work with, or how does that work? So
we do a lot of that to an extent. If a person comes in and has a cancer, there's a lot of lab studies that happen. Maybe we find out there's a genetic mutation. If that's the case, we help align their family members with genetic testing. So we can help in that regard. I would say a lot of the things, in terms of general prevention, this is not news to you, but getting established with a good primary care doctor is probably like the most important thing in terms of like preventative medicine for everybody. Right. Screening recommendations change. And for example, like there's more colon cancers in younger people now.
Why is that, by the way?
I don't know.
That's so crazy.
I don't think anybody knows. But and just over the last few years, the screening recommendation for everybody who's at a normal risk, who doesn't have a family member who had colon cancer or died of colon cancer, they should start being screened at 45. It used to be 50 a couple years ago. Yeah. It's different now. So those recommendations change. And that's a big change. That's 5 years. So if you're a person that doesn't have a primary care doctor and you're kind of like the normal 42-year-old man who wouldn't know that the screening recommendations have changed. Soon you're 45, 48, and maybe you still haven't been screened. And so a good primary care doctor is going to make sure you're on top of all those screening studies. They're going to be doing labs. They're going to be checking your vitals when you come in and making sure that you're healthy. And then they're going to be giving you advice and medications to make sure that you get more healthy or stay healthy. Right. And that's such a good piece of advice. It's simple advice, but I think there's a lot of people out there that do not have PCPs. So I'm a doctor and I did work as a PCP and I just got a PCP last year and I'm 41 years old. Well, preach to the choir. I'm embarrassed to admit it, but I'm admitting it now. Yes. So I should have got one sooner. Yeah. And everybody needs a primary care doctor. Absolutely. Because I think, like you said, it's just like these basic screenings that you wouldn't know to go do, of being able to do that, to catch these things that you can live a longer, healthier, happier life. Yes. Absolutely. Yeah. Do you even think like even, the healthiest person you could possibly think of, like there's still somebody that should be screened and, as they go through their ages, right? Yes. Because again, I think that's another thing is somebody will say, well, I run every day. I do this. I eat healthy. I eat clean. Yeah. I'm good. I don't need anybody. Yeah. And then they don't go to the doctor until they absolutely need to, right? Absolutely. I understand. Yeah. Everybody needs a primary care doctor. Sure. Yeah. So when we're talking about somebody that has chronic illness, when we're talking about like wellness for that person, what does that look like? Even like going down to like their diet. Yeah. So in terms of just patients that I meet, and, I know that I think wellness, when you talk about it, it's kind of like now it's like a loaded phrase. It is. And sorry. No. I think
loaded
it's,
question. Like how much time you got?
Cool with these questions. This is a hard one. Sorry. How much time do we have? Sorry. I'm always trying to protect everybody's wellness, their quality of life. I want patients to live as well as possible. I think that the wellness industry is like a different thing. To me, keeping patients well means staying on top of things and managing things as they arise. Yep. And making sure that I'm not putting them in danger by any of the medication, management that I'm doing, and making sure that they're having, good days. I don't specifically make a lot of like dietary recommendations, just because I don't know a lot about the things that people are recommending, no matter how evidence-based or not they are. Because I have patients every day that ask me, cancer patients that ask me, hey, what should my diet be?
Right.
And then I say, well, what are you eating now? And if they're eating a healthy, well-balanced diet for the most part, I tell them to continue doing that. Now, cancer and treatments can cause symptoms. So sometimes we tell people to change kind of like their approach to eating. Maybe they're eating smaller, more frequent meals to make sure they're getting those calories and making sure that those symptoms don't get bad if they eat a big meal. So, we kind of talk about eating and nutrition in that way. In a lot of ways, I think that's kind of like a blind spot, but it's also not a well-established part of like oncology care. So we're never recommending like, whether it's like zero sugar or ketogenic or things like that. If you Google that, you're going to get thousands of hits, and that's what people do. And if they've been on a diet like that and they feel good on it and they're maintaining their weight, maintaining their health, that's okay. But I don't make any specific recommendations about like dietary modifications that they should or shouldn't be making. So I hope that.
No, you got an A+. That was an excellent answer. I don't know if I could have answered that. Tell me about, you mentioned it a little bit earlier, but tell me how mental health plays a role in all this. And do you work with psychologists? Who do you work with for that? Yeah,
so I would say mental health, behavioral health plays a huge role in all of this.
Absolutely.
In my mind, anxiety, depression, for people that are going through what cancer patients go through, I think it's underdiagnosed a little bit. I think the reason it's underdiagnosed is because I think when providers see those patients, they think, oh, of course this person's depressed. They just found out that they have, this new diagnosis that's in its advanced stages, and they kind of all chalk it up to being situational. The thing that I tell patients is, if you're waking up at 2 or 3 in the morning, multiple times a week, and you're anxious and you're stressed out, I want to put you on medicine for that, because I want to treat that to make sure that we're protecting you're getting good restorative sleep, and you probably have some anxiety and depression that yes, maybe those types of feelings are normal right now, but it's not normal to have them every day. And it's not normal for them to limit you being the person that you are. So I do start a lot of people on new anxiety and depression meds, but I also see a lot of people that are on all of those medicines before, and I'm adding to some of the things. I see patients that might have other complicated behavioral health concerns, whether it's bipolar disorder or schizophrenia or schizoaffective disorder, and they might be on some pretty heavy-duty psychiatry medicines that they've been on for a long time. So I do have to be careful about things that I add, and it's always like a constant adjustment. So mental health, behavioral health plays a huge role. I do refer frequently to a therapist that does cognitive behavioral therapy in the area, and they offer all kinds of different behavioral therapies too, and they meet a lot of our patients. And sometimes patients who are going through something really difficult and are having a lot of mental health issues and behavioral health issues, sometimes they want to try medicine and not seeing a therapist. Sometimes they want to try seeing a therapist and not medicine. But I always tell people, if you're majorly depressed or you have a lot of anxiety, medication and therapy together helps more than either one alone. So I'm always, working with patients, and, I do start a lot of patients on new medicines for anxiety and depression, because I personally feel like that goes a little underdiagnosed in my patient population.
So I used to work out in Pittsburgh when I was in school. I went to Pitt for grad school. and I worked in the UPMC health system and like their clinics. And I'll never forget, they had this commercial that's always stuck with me, and it would pop up on my TV, when I was studying, it would pop up, but it was showing just like a medical hospital, and they were just kind of showing, the doctors walking by, getting in the elevator, patients being wheeled around, and it was just music, and they were saying like what each person in that film was going through. So it was like the person getting wheeled in a wheelchair just found out that they are cancer free. The doctor who just entered the elevator just had to tell his patient that he's been treating for 10 years that they have 2 weeks left to live. Yeah. They were showing, one of the support staff that just lost their husband, 2 weeks prior. Yeah. But it's always stuck with me because, especially for what you have a really tough job in some aspects of, having these really difficult conversations with people and being real with them, not just giving false sense of hope often. Yeah. But I think just in general, what I'm trying to say is just be kind. You just never know what people are going through. Yeah. And I really, it's really cool that you're able to do something like that. Yeah. And it's really complicated what people go through. Yeah. And, I see patients every week who they have improvement in their cancer. Yeah. And I've met people that it's completely unexpected to them. Right. And they're shocked. Right. And they almost don't know how to feel. Right. And it's so complicated. Like what I'm trying to say is it's so complicated that, the mind is so complex. Right. And, I hear different stories. What I like about my job is I get to hear different stories every day. And I hear people's stories and I try to work with them to make sure that they can continue being, the person that they are. Sure. And, it's so complicated that even on a day where maybe one person would think they want to celebrate, they're like, oh my God, I don't know how to feel about this because maybe they didn't expect it. Or I had this idea that, this wasn't going to go well for me and I'm not even sure how I feel about it right now. It's so complicated what people go through on a day-to-day basis. And being able to be like a first responder in those moments and just hear what they're going through is something that's like a real privilege. Totally. You hear people's stories and you watch their stories go on and a lot of times it's really sad, but a lot of times, like I said, there's successes and success isn't always measured in pushing people as far as they can go. Yeah. I think, it's measured in protecting what's important to people. Absolutely. Yeah. You pretty much just asked my next question, which was going to be, what is one of the favorite parts about what you do? And it sounds like that's probably it. Just see above. My next question is, what do you think is one of the hardest parts of your job? So every day is hard and it's hard to hear something so complicated. In the medical field, the healthcare profession, we're trained to kind of always have an opinion right away. And sometimes the hardest thing for me is I want to make sure that I listen to people. Yeah. And sometimes that's all I can do. Sure. So somebody can be going through something so severe that I don't sometimes have good advice. And all I can do is listen. But that's okay. Sometimes that's enough for people. But I think more providers need to be okay with that. Right. It's okay to listen to people and not have an immediate recommendation where you're just trying to kind of throw things out there to keep, conversation. It's okay for things to let it sit for a second. To let there be silence. Yeah. This might sound weird, but I'll be in a room with a patient and sometimes a minute will go by without anybody saying anything because everybody's listening to each other and everybody's kind of trying to take in everything all together. And I'm sure, if I was a patient, I would appreciate my physician just sitting with it. And I would be okay if you didn't say anything right away because I'm like, this is a lot. Yeah. He needs to also process what's going on and how what he thinks is the next big step. And I think if you're just trying to answer and put something out right away, it's almost like, did you just say that just because he kind of wanted to, or he or she wanted to fill the void, fill or space. Let's just do this. Like I'm doing right now. No, but you know what I mean? It's just, I think people appreciate more than because we're all human. They appreciate more than you think. he's just taking his time to understand, like, this is the next best step for you.
Yeah. And if you've ever known someone really well, if you're lucky enough to have like someone in your life that you know really well and that knows you really well, you can sometimes just sit there.
Absolutely. Those are the best people.
Not say a damn word.
We're going to sit here for the next 5 minutes in silence.
So,
it's great.
That's sometimes what people need. And
I agree.
Yeah, that's okay.
Yeah.
Yeah.
I'll even have patients ask me something, about a different injury that's popped up, or how does this affect this? And I'll just frankly tell them, I actually don't know, but I'm happy to do the research for you, and I'll get back to you next session,
I think.
But I think people appreciate it, other than me trying to spew some yes answer. That they're like, you just made that up.
Yes. And in a way,
and I'd rather tell them, like, I'll look it up. Like,
you're also validating how complicated things can be. And you're an expert in your field. It's okay to just say, hey, I don't know. I'm working on it, and I want to meet you where you are and help you. Right. And it's like,
even
if you don't know, you're still going to do that.
Yeah. So it's like, I know where to look. I'll do my research. I'll talk to people who may know that better and be able to give me an answer. Yeah. And we'll both learn from this, But I think it's better to have that humility no matter what profession you're in. It makes you a better clinician or just person overall.
100%.
But this was absolutely fabulous. I could have sat here and talked to you for hours and hours. But of course, I'm sure there's going to be people that want to know where you're at or, website details, like any other social media. So please tell the crowd where they can find you.
So we're consultants in medical oncology, hematology. I do the embedded palliative care there. We're located in Broomall, 30 Lawrence Road. For everybody from Delco, it's the old Pathmark. We have a new location in Newtown Square. I don't know the address.
We'll link it. We'll link it on here.
I know it's near Spread Bagelry.
Yeah.
That's how I know it.
Doing a tap house.
That's how I know where I'm going.
Next door.
So we have one in Newtown Square. We also have a location in Glen Mills. So we have a few locations. We're always seeing new patients. We see patients for hematology and oncology. Of course, that's why the practice was started. Mm-hmm. And I see patients for palliative care. It can be patients from outside the practice. Most of the people I see are inside the practice, but I'll see anybody from outside the practice.
Yeah, absolutely. Mm-hmm. Well, thank you so much for coming out. This was so fun.
This is great. Yeah.
I appreciate it.
Thanks. I appreciate it.
Awesome.